Welcome to Voices of Experience. Change is underway in the healthcare system for Americans. We need to understand this change and how the Affordable Care Act, commonly called Obamacare, affects the choices of consumers as they try to access the healthcare system. So I'm Dan Michael, President Emeritus of the Minnesota State Retiree Council, AFL-CIO, and I'll serve as host for today's program. Joining us today is Pete Benner, a member of the new MNCare board that will oversee the health exchange program. Pete, welcome to Voices of Experience.
Thank you.
Okay. So I have to say at the beginning, I know of no other person in Minnesota or in this region who is more knowledgeable about healthcare matters than you. So now why have you taken to exercise and enhance your considerable knowledge by serving on the MNCare board?
Dan, I had spent most of my working life with AFSCME, negotiating health benefits on behalf of public employees. Mm-hmm. As part of that, it became very clear to me that bargaining with our employer simply is not sufficient to try to get us all affordable, quality health care. And on behalf of the AFL-CIO and other unions, I started to serve on a number of the governor's task forces, first for Governor Perpich and all the way through actually now for Governor Dayton. And that's a career of trying to come up with reform ideas. MNCare is actually going to implement reform. And when the opportunity came up to serve on the board, I just could not pass this up. This was actually an opportunity now to bring affordable health care, quality health care to all Minnesotans.
This is a fulfilling of your career.
It's a culmination of my career, yes.
Culmination, yeah. Okay, let's get practical. When does the health exchange portion of the Affordable Care Act begin?
Dan, it's going to start officially on January 1st. That is when the new products will become 2014 available for coverage. Open enrollment will be starting in October 1st, basically. Mm-hmm. So for the last 3 months of this year, people have an opportunity to look at what's available, compare the plans, figure out what their part of the cost will be, and then sign up for coverage that begins in January.
For how long has the state of Minnesota been preparing for the start of this new program?
This started almost immediately after Governor Dayton assuming office in early 2011. Mm-hmm. He had hoped to come up with an agreement with the Republican legislature at that time to set up a health insurance exchange for Minnesota. The legislature was not interested, so later on in 2011, the governor started to implement things within his control by executive order. And so in the back end of 2011 and all through 2012, state employees were working to put together the backbone of the exchange. And then with the 2013 session, with the Democrats back in control, the governor and the House and the Senate were able to agree upon legislation to implement the exchange. And that work has now been going full throttle since the end of session.
Now, we have been working on that for the state of Minnesota. Are other states going through the same process?
Many are. There are probably about half the states or so are going to be running exchanges that they control. The other half are going to be running exchanges or will have exchanges that are run by the federal government. Even in 2011, there was a strong consensus among Republicans that if we had to have one, it ought to be one where the state itself has much more control over it than if it's run out of Washington. But they couldn't figure out how to do that. Wisconsin, our next door neighbor, will have a federally controlled exchange.
So what we are looking at in this health exchange is a bridge to Medicare. And for people, this starts at age 65. And let's take before we get into that bridge part, let's take just a quick review of Medicare. Medicare Part E, how has the financial stability of that been affected by the Affordable Care Act?
Part of the Affordable Care Act was to increase the payroll tax for high earners, essentially couples making $250,000 a year or more, increase that payroll tax beyond what it is today. And based on that, the most recent report of the Medicare trustees said we got 2 more years now before Medicare runs out of money in its trust fund. So now this is something like, I think, 2026. So it's done a major part of ensuring the financial stability of Part A.
Okay. And Part B?
Part B, the Affordable Care Act moved a set of preventive services before the deductible, before the coinsurance is on Part B. So seniors now can make sure they get their annual physical, the flu shots, other tests without having to pay anything out of pocket.
I'm smiling at that because I had my Medicare wellness physical yesterday.
Good man, good man.
As a matter of fact. So, now in the Part D of Medicare, this is the controversial part, especially the prescription drug coverage. We had the famous or infamous donut hole, where people were paying a certain amount of money after the deductible. I think it was almost $3,000, $2,970 in prescription drug cost, and then they continued to pay the premium, but received no benefits until they got up to $4,750 in expenses. So they clawed their way out of this donut hole. Does this Affordable Care Act, Obamacare, does this maintain this donut hole? Does it expand the donut hole? Or does it contract the donut hole?
Probably the biggest Medicare change out of the Affordable Care Act is to close the donut hole.
To close it?
To close the donut hole and have the same level of coverage as we have pre-donut hole right now, which is essentially that Medicare pays 3/4 of the cost of a drug, and then the consumer is on the hook for 1/4 unless they buy supplemental policy. Starting in 2014, they've been narrowing that donut hole a bit each year, and by 2020, the donut hole will close completely. For seniors buying supplemental policies on the open market, we've actually seen a stabilizing of what those premiums are from year to year, and I think the biggest reason for that is the closing of the donut hole.
Very good, very good. Now let's talk about health exchange. What's the basic purpose of a health exchange?
The health exchange is going to do 2 things. First, it is the vehicle through which the tax credits passed by the Affordable Care Act become available for people in the individual market. Second, it will be a vehicle whereby individuals and small businesses can look at a set of policies side by side, compare and contrast, and then much more simply than they can today enroll in those policies. So the exchange, as I say, is going to do 2 things. It is going to be the vehicle for the tax credits, and secondly, it'll be a side-by-side market for pre-65 coverage, just like in some respects senior linkage line today is a way to do side-by-sides on the Medicare supplements.
Let's tackle that tax credit issue. How do I know how much I'm going to get and when I get it? How does that tax credit work?
The tax credit, actually people are going to have a choice on this. They could have the tax credit apply to their monthly premium, and so you'll never see it. It'll go directly to the health plan. And then there'll be a settle up if necessary when you file your income taxes in the subsequent year. Or you can pay all the premium cost on your own and then get all the money back when you file your income taxes in the subsequent year. Given the income levels of folks eligible for the tax credit, it's highly unlikely people are going to take the second option. No. Most are going to take it, put it directly to the premium.
Okay. So who is eligible to use the health exchange, and how does one prove that you are eligible?
The simplest way of looking at it is to say anybody who is not eligible for a public program like Minnesota Care or Medicaid, and then anybody who does not have what is deemed affordable coverage through their employer. So self-employed people, people who are not eligible for coverage with their employer, all pre-65 retirees, even if they are getting some contribution from their employer, are conceivably eligible for coverage. And then some people will be eligible even though they work full-time, get some contribution from their employer, but that contribution from their employer is not sufficient.
So this is opening up the field, isn't it?
This is opening up the field. I have a nephew who has aged off his parents' plan. He strings together a set of part-time jobs, none of which offer him insurance. My nephew is going to be eligible to apply for the exchange, then depending upon his income level, will be eligible either for Medicaid or for a tax credit to buy a plan on his own.
Now, during the course of this program, our crew is flashing the website for
Very good.
for MNCare, and that's really a great website to go to. What happens if you're not comfortable going to a website type of situation?
People are going to have a number of choices. The easiest will be doing the website, and you could effectively do all your enrollment through that without needing any outside help at all. If you want help, we are setting up what are called helpers, assisters. Some will be called navigators, some will be called in-person assisters, some will be called certified application helpers. But in each case, they will be folks who are trained on how to navigate the site, on how to help you apply, and then you can sit down with them person to person or by phone, and then they will help walk you through that site and help you do the enrollment directly. So no one has to do this on their own. The website will be saying who is where you have assisters or helpers available to you in your area. We think there will be dozens, if not hundreds and hundreds of community organizations signing up to do this and get their folks trained. So people ought to have somebody in their community they can go to for help.
So that could be a person-to-person, face-to-face?
Person-to-person, face-to-face.
Okay. And you get started in that via telephone number to...
Yes, I mean, there's going to be a lot of media work this summer, and I think as the navigators and assisters get trained and get ready to go online in October, you'll be seeing a lot of work by some of them also to make it known to people in the community where you can go to help.
Okay. Is using the healthcare system, or is using the health exchange mandatory, or is it an optional aid?
It's optional. If you currently buy through the individual market, like the plan you have a good relationship with a broker or an agent, or just are comfortable sending in the renewal notice every year, you can continue to do that. But if you want the tax credit, you have to go through the exchange. Just let me give you a couple examples, Dan, on what this tax credit can mean for people. A senior couple, for example, making $50,000 a year, the tax credit would buy down their share of a premium for both of them to a little under $400 a month for a policy that is more comprehensive than probably what they're buying now as an individual. For a couple making $40,000 a year, the tax credit will let them buy their premium down to about $275 a month. Far, far less than these folks I'm sure are paying right now on the individual market. And even some people who still have a bridge to Medicare from their employer, unless they were really lucky, and have an employer who's paying all but the vast majority of the premium. My guess is some of them will find that buying through the exchange will be a far more reasonable way of getting affordable insurance.
Now, what companies will be listed on the health exchange?
We don't know the answer for that for sure yet. Health plans had until the end of May to say they wanted to apply to offer plans, so that has happened. We know that Health Partners has offered, has applied. We know that the Blues have applied. We know that Preferred One has applied. We know that UCare has applied, and there are some others, but we don't know precisely what they have applied for. We don't know the premiums yet. We don't know the networks yet, and we probably will not know that until well into September or maybe even October. So folks are going to have to be very alert when all this goes live at the back end of the year.
Yeah, but as you said, October, November, December.
3 months.
3 months, and the insurance companies will get their act together, and people have a chance to study this. And
Have a chance to study. And an important part of this, Dan, is that part of the Affordable Care Act says that a insurance company now has to take everybody. They can no longer refuse to cover you based on a pre-existing condition, and they can no longer bump up your rate because you or a member of your family happen to be sicker than normal. So one of the things that has discouraged people from buying through the individual market to date has forced a lot of folks into MCHA in Minnesota. This is a high-risk pool for people that couldn't get coverage on their own. That's ended. As part of this open enrollment, even if you have a diagnosis of cancer, your spouse has a heart condition, you still will be able to buy coverage from any of these health plans, and they can't charge you any more than they would charge a healthy person of the same age.
Okay, very good. Now, just to clarify one point, the use of the health exchange is optional.
Yes.
It's there as an aid to guide you through. Is health insurance itself mandatory?
Health insurance becomes mandatory as of 2014 for people of all ages. If you do not have coverage, you will be subject to a fine as part of your federal income tax filing. I think for the first year, this fine is very minimal. Even for the first numbers of years, these fines are very minimal, but they exist. So if you do not get coverage, and by the way, having Medicare is deemed coverage.
Okay.
Buying any of these plans through the exchange will be deemed coverage. In almost all cases, the plan you get through your employer will be considered coverage. But if for some reason you want to run naked, have no coverage, then yes, you will be subject to the mandate to pick up coverage or pay a fine through your income tax.
And the purpose of the mandate is to create a broad pool, so that it's not just sick people who are in this insurance pool.
Yeah, the challenge here is that if you do not require everybody to be in the pool, you get back to the situation we've been in the individual market for forever, which is to the extent that healthy people don't come in, the premiums for everybody else get higher and higher and higher.
Yeah. So now, in going to the health exchange, let us assume, and you make a decision. Is this a one-time for life decision, or if your family circumstances change, can you at a future time and date change what you have?
This is going to run very much like Medicare does today. There will be an annual open enrollment. And so every fall you'll be able to change your health plan, either company or type of coverage, and for next January. In addition, as people lose, say, employment-based coverage because they've retired early, that will make you eligible to apply. The same sort of kind of life events right now that would trigger somebody to be looking for a different insurance policy will apply here also.
Okay. Now, you are a member of the MNCare board, which oversees the exchange system. As a government teacher, is this part of the legislative branch of government, the executive branch of government, or judicial branch of government, or is this something else?
We are something else.
Okay.
The exchange is a state agency, meaning the workers are state employees. A big part of the debate over the bill this past session was whether or not to make this a private company, and there just was lots and lots and lots of concern by legislators that we did not want this to just become another insurance agency, another insurance company. This had to be different. The board is nominated by the governor. We will each have to be confirmed by the House and the Senate.
Both.
Sort of like the Board of Regents.
Yes.
So we're an independent public agency, sort of like the MNCare, the state university system, community college system, independent board, I think that gives us the best of all worlds here. We have the security of being an ongoing state agency, but we are not beholden to any one governor. We're not beholden directly to the legislature or to the judicial branch.
How many people are on this board?
The board is 7 people.
Okay. Is the insurance company represented by any of the 7?
No, they are not.
Insurance companies, I should
No,
say.
part of the law says that none of us can be employees now or recently of an insurance company, of a hospital, of a clinic. We can't be part of the industry in that sense.
So we don't have the wolf helping to guard the hen house.
I'm not sure it's the wolf in the hen house, but it is to make sure that
I said that. You did.
Yeah, it is to make sure that we are truly independent.
Okay. How are persons and families how will they benefit from this program? That's part of the overall, Affordable Care Act, part of the overall Obamacare.
Couple things, Dan. The Affordable Care Act, and then in the exchange here MNCare becomes the vehicle for this, is to make sure that people can understand the health insurance offerings they have. Right now, if you go to the open market, plans have wonderful names for stuff, but based upon what they call it, you can't tell what it is. The law now says basically there will be 4 levels of plans. They're calling them metal. Platinum plan, a gold plan, a silver plan, a bronze plan.
Okay.
But it's essentially saying how much coverage the plan will provide. So you know that regardless of what interesting name a health plan says, if you're buying a gold plan, that is telling you that on the average, this plan will cover so much of your costs. And so you're not going to get surprised by out-of-pockets when they hit. It's also going to let you compare the gold plan from the Blues versus the gold plan from Health Partners versus the gold plan from Preferred One and whomever else. So you know that regardless of what company you pick, you're likely to get roughly the same coverage. It's also going to let you compare the networks so that if you're really concerned about going to your current doctor, you can easily find out that of the options I have, these 5 let me go to my current doctor without a problem. You're going to be able to find that out. Then I think to me the most important part is the exchange is going to make care affordable for ways it isn't now. If you're a pre-65 retiree and are not blessed with an employer contribution to the coverage, if you want to stay with your employer group, you can wind up paying $600, $700, $800 a month just for yourself. If you're trying to cover your spouse, husband or wife, put another $500, $600, $700, $800. All of a sudden, you're trying to get by on $1,500 up to $2,000 a month in health premiums. And I know what public employees get in their pensions. Yeah. And you pick a survivor benefit, that's your pension if you're lucky. Yeah. It probably is more than your pension. I gave some examples earlier. It is conceivable that depending on what coverage you want, for the type of pensions, at least public early retirees get, you're going to be able to slash that down to $300, $400, $200 a month, depending upon your income. That's a big deal. Yes. I can't emphasize that's a big deal. I think early retirement now is something that, assuming you can put a pension and maybe a part-time job together, you no longer have to sweat out the health coverage. I talked about my nephew. If I am eligible to apply for early Social Security now, I'll be eligible to apply for Medicare in a year and a half. I will have a son under age 25 at that point. If something were to happen to me, he will now have a way of getting decent coverage. At the point he ages off my plan, when he turns 26, he will have the ability to get decent coverage. So for our kids, in your case, Dan, maybe your grandkids, I think they're going to be in a far more secure world than those kids and grandkids were in just a couple years back. And for our, for the people we know who are self-employed or who are stringing together the part-time jobs and who either couldn't get individual coverage at all or who who had to buy the $10,000 deductible plan, the $5,000 deductible plan to make it affordable for them, they're going to be able to get maybe not Cadillac coverage, but they're going to be able to get really decent coverage, depending upon their income level, that they couldn't get before. I mean, the tax credits go up to 400% of poverty. And for a single person, that's $45,000 a year. For a family of four, that's something in the $90,000 a year range. So this is just not for poor people. This is for average middle-class folks.
So I know back when I was getting ready to retire, and my friends around my same age were getting ready to retire, the number one impediment to early retirement was health care costs.
Yes.
And people were looking at that and wincing, and okay, I'll keep on going, and this will help people in that kind of situation.
Big time.
And that has all kinds of benefits.
I mean, it opens up jobs for our kids and our grandkids.
Yes.
It lets our employers bring in people lower in the salary range.
Yeah.
And I think, as you and I know, as being semi-retired, and you, truth be told, are also semi-retired in practice.
Yes.
There's all sorts of other stuff we can be doing that is, in a lot of respects, far more exciting and interesting than what we did 9 to 5.
So we've talked about a lot of ideas, and do these new ideas solve all the problems for the foreseeable future?
No, they don't. Okay. There's a lot of work left to do. The Affordable Care Act has some holes in it. There will be people for whom the law says your employee only or single coverage is affordable through your employer, but coverage for your family isn't. The law does not fix that problem. There may be some things we can do in Minnesota to help address that, but the law does not fix that problem. I think it is still a bit uncertain as to how well the mandate is going to work. If we are not successful in getting enough low users of health care enrolled, premiums are going to be higher than they otherwise would need to be. Now, having said that, the tax for people eligible for the tax credits, those tax credits are paid to your income, or are pegged to your income. So even if the overall premium is higher than we would like it to be, the tax credit will buy it down to a certain percent of your income. But that's going to put greater pressure on us to, especially on the federal government, to be able to raise the money to support those tax credits going forward. So no, this does not solve all problems. Finding a way to really address the ever-escalating cost of health care has to be part of this discussion, and finding a way to provide affordability in practice for everybody remains part of this discussion.
Pete Benner, our award-winning director, Roger Carlson, is telling me we just have a minute left.
Okay.
And I want to thank you for your longtime service to your union and to the entire union movement, but especially for your knowledge and expertise in the healthcare field as you advocate really for all consumers, and we really have to continue to be informed on this healthcare exchanges and in other developments. So, thanks to our crew, Bill Moore, Dick Nielsen, Ed Rapp, and please join us for our next program when we will feature House Majority Leader Aaron Murphy as we will recap the 2013 state legislative session. Thank you for watching.